Good day, everyone, and welcome to class, Best Practices in Serving LGBTQ Individuals and Families. So what we want to do right now is we're going to talk about quick facts before we begin to go deeper into the presentation today. There we go. Now, a couple of quick facts about the LGBTQ communities. As we can see here on the screen, most research suggests that GLBT people are likely to be at higher risk for depression, anxiety, and substance use disorders. A study also found that the LGBT groups are about 2.5 times more likely than heterosexual men and women to have had a mental health disorder, such as those related to mood, anxiety, or substance use in their lifetime. And in a national study comparing LGBT groups and heterosexual groups, researchers found that gay and bisexual men were more likely to report major depression and panic disorder in the previous 12-month period, and lesbian and bisexual women are more than 3 times as likely to have experienced a generalized anxiety disorder. So with that being said, we are finding out more and more as we become more aware and open to the LGBTQ communities that there's a definite need for not only mental health treatment but ALD treatment as well. So what has to happen is that we have to have standards that are culturally appropriate, culturally responsive, so we can provide the most effective and equitable treatment to our LGBTQ brothers and sisters. So why are standards of cultural responsiveness important? Because without standards of care and training about the LGBTQ issues, many of the LGBTQ identified clients will experience the same types of harassment, discrimination, or invalidation as they experience elsewhere in society. Such stigmatizing experiences may harm LGBTQ clients and decrease the rates of program enrollment, engagement, and retention, and diminish positive outcomes. And what we want to make sure that we aren't doing as an agency or as individuals is promoting premature termination. And the way that we can decrease premature termination in regards to treatment is to become more culturally responsive and aware of our LGBTQ brothers and sisters. So in order for that to happen, we created, or the class standards for the LGBTQ communities were created. Again, LGBTQ stands for lesbian, gay, bisexual, transgender, queer, questioning individuals. The acronym has since expanded, and we will go into that later in the presentation. It's actually now, and of course I'm sure it's growing as we become more culturally responsive and inclusive, it is now LGBTQIAA, and the LGBTQIAA stands for lesbian, gay, bisexual, transgender, queer, questioning, intersex, asexual, and ally. So we have these 5 standards created to empower our LGBTQ brothers and sisters, and again to provide equitable treatment. If we look at the slide, it says that one of 8 committees that advise the ADP, which is now DHCS, in developing strategies to plan and implement culturally competent alcohol and other drug abuse prevention, treatment, and recovery services. And in 2008, this particular committee and the LGBT TriStar developed 5 voluntary standards of care for providing culturally and linguistically responsive services for the LGBTQ populations, including action steps to promote them. So we do refer to those as the 5 LGBT class standards. Those 5 standards are the LGBT inclusive policies and procedures, the LGBT basic training and supervision of staff, appropriate language, welcoming and inclusive climate, and linkages, referrals, and resources. So the next question is, why should we focus on the LGBTQ communities? And what we found is that there is a higher rate of health problems related to minority stress, which means that the LGBT people will be overrepresented among people needing healthcare services in the near future. Also, many clients have had same-sex experiences or attractions that may need to be addressed in their treatment and recovery. And also, as we understand unresolved sexual issues can be triggers for relapse. Another reason we should focus on LGBTQ, our LGBTQ communities is to eliminate heterosexism. And if we aren't familiar with that term, it's the assumption that all people are or should be heterosexual. And it also means that it excludes the needs, concerns, and life experiences of lesbian, gay, bisexual, and other non-monosexual people, as well as asexual, transgender, and intersex people, while it gives advantages to heterosexual people only. It's a subtle form of oppression which reinforces the realities of silence and individuality. So we have to make sure that we are eliminating heterosexism not only in our professional lives, but hopefully in our personal lives as well. Another reason to focus on the LGBTQ communities is to eliminate homophobia. Now, the difference between homophobia and heterosexism is that homophobia is the irrational hatred and fear of homosexuality. The disapproval of homosexuality overall, we call this a motive. And this includes prejudice, discrimination, harassment, and acts of violence brought on by fear and hatred. And we can add microaggressions into that pot as well. And this can occur, homophobia can occur on a personal, institutional, and societal levels. And another reason why we should focus on LGBTQ is that all clients deserve respect, and stereotypes can harm people by reducing them to a narrow set of characteristics that erase their individuality. And equal access to treatment does not mean that all clients or communities have the same needs. They may need to receive different services according to their unique characteristics. And all agencies can and should be LGBTQ responsive. Some agencies may go further and provide LGBTQ-specific services, but we want to make sure that we are definitely attempting to make sure that we are providing the most effective and equitable treatment for our LGBTQ brothers and sisters. And we want to make sure that we're staying away from stereotypes. As we know, stereotypes are fixed, and if we are careful, we could unintentionally provide a disservice for our brothers and sisters in that way. So then, another reason why we're going to focus on LGBTQ is that most clients have sexual issues or concerns related to their substance use and abuse. So learning to talk about sexuality and gender more openly will help most clients. And then it also talks about all agencies should provide physical, emotional, and spiritual safety for all clients to feel safe. Marginalized groups may need to feel that they are being seen as who they are by their treatment providers. So that includes being culturally responsive and culturally proficient as well. So the next question is, why are some people LGBTQ? There's been a debate, a long-standing debate, actually, about whether a person identifies as LGBTQ because of biological facts or if it's caused by the environment. And as we see here, a few studies examine hormones, neuroanatomy, genetic markers, family history, and childhood experiences and behaviors. And what came up was the result was none of them conclusively demonstrated either a biological or an environmental cause of sexual orientation or gender identity. Some causes have been ruled out, though. Differences in sex hormones and dysfunctional families. We have learned that those are not in any way a catalyst for an individual identifying as LGBTQ. Another reason we ask that question is that sexual and gender identity orientation may be a combination of biological and environmental factors that can vary from one person to another. So we want to make sure that we are individualizing the treatment of the individual regardless of their sexual orientation, their sexual identity, or gender identity. You have to remember that the person that's in the room with you is an individual, very complex, and there are different aspects to the individual that we are to respect and to hopefully ask the culturally responsive questions around to gain more information to further contextualize what may be going on for the individual. The next is most people, including LGBT people, experience their sexual orientation or gender identity not as something chosen, but rather as a core aspect of the self. So if we are not asking that question, if we are feeling uncomfortable around asking those particular questions around gender identity and sexual orientation, again, we would be unintentionally doing a disservice to our clients because we are dismissing that core aspect of the self. We want to make sure that we are very thorough in our treatment. We're going to switch up a little bit and talk about the diversity in the LGBTQ community. As we see in our bullet points, the LGBTQ community are within all of these particular subcultures and many more. And we just bullet pointed a few. They're racial ethnic groups, religious and political groups, geographic regions, age groups, socioeconomic classes, and mental and physical ability groups. And we have to remember sexual orientation and gender identities interact with other cultural factors to produce a diversity of LGBTQ subcultures. So a wonderful mix of individuals make up the LGBTQ communities. Something else about diversity within the LGBTQ community. What is pointed out is that across race and ethnic groups, milestones of sexual orientation are the same. Age of first same-sex attraction, age of first same-sex experience, age of coming out to self. And among diverse groups, excuse me, differences occur in the degree of disclosure, labels used, and ideas about the relationship between gender and sexuality. So we're speaking about developmental periods as well as individual characteristics. We want to make sure that we are teasing out that information and able to categorize them where they are appropriate. But we want to make sure that we're asking those questions, stepping out on our own confidence and asking the very pertinent questions. Another point I'd like to make about the LGBTQ population diversity and individuality is that providing culturally responsive services to the full diversity of the LGBTQ individuals requires awareness of how multiple aspects of identity interrelate to each other. So what we're going to talk about now is the action plan for the 5 class standards for our LGBTQ brothers and sisters. So again, LGBTQ stands for lesbian, gay, bisexual, transgender, and queer, and questioning. And then class stands for culturally and linguistically appropriate services. Okay? So if we take a look once again, there's a list of 5. The LGBTQ inclusive policies and procedures, the LGBTQ basic training and staff supervision, appropriate language, welcoming and inclusive climate, linkages, referrals, and resources. So the class standard 1 is about the inclusive policies and procedures. And here, as we can see, it states agency policies and procedures are inclusive of LGBT staff, clients, and communities. And as we have talked about earlier, we want to eliminate the idea of heterosexism. And again, this is an example of an unintentional disservice, as most agencies are heterosexist, meaning that there is no indication in their daily operations that some of the staff, clients, and communities they serve are LGBTQ. We want to make sure that the agencies are taking the steps to examine their policies and procedures for evidence that LGBTQ people exist and are addressed in the agency's documents. Sorry. Now, the next standard, I'm sorry, before we go on to the next standard, I do have an example of what the standard 1 may address. One of the things in particular is confidentiality. And we want to make sure that it includes a statement that the staff members honor the confidentiality of LGBTQ clients and ask permission to record information about sexuality and gender on their official records. Honoring confidentiality and privacy rights is a matter of survival for clients in LGBTQ hostile environments. So we want to make sure that we are safe as well as effective and efficient and equitable when we're providing services. We want to make sure in regards to sexual harassment that there's a policy in place and that it includes same-sex harassment as well. So that's an example of what the Class Standard 1 should entail. Class Standard 2 is referring to basic training and supervision. And as we can see, it's really about staff members at substance abuse treatment or prevention agencies receiving basic training as part of their larger diversity training experience and receiving appropriate supervision to provide inclusive services for our LGBTQ brothers and sisters. And it also states in this standard that staff members who provide poor quality of care should be or are appropriately sanctioned. Now, an action step in regards to Standard 2 is to ensure that at least one continuing education program per year includes LGBTQ issues. And we want to ensure that all staff members providing direct services to clients receive basic training in LGBTQ issues, and that some staff members, at a minimum, clinical supervisors, receive more advanced training, and this should be done annually. We also want to make sure that the agency policies about staff conduct include language about the sanctions for violating the respect and dignity of clients or staff members. Grievance policies should be in place and explained to clients during intake. Those are examples of action steps for Class Standard 2. The next standard we're going to talk about is Standard 3, appropriate language. We want to make sure that the written forms and documents and oral language used in assessment and interventions are inclusive and respectful of LGBTQ people. And that would look like written documents such as client brochures, intake forms, and outreach materials, and oral language used in assessments and interventions that set the tone for inclusion and hopefully not exclusion. So an action plan for that is if the intake forms have no place for LGBT clients to indicate their primary identities, relationships, or families, the agency will not have the information it needs to provide services responsive to their needs. If group facilitators only talk about heterosexual relationships and husband and wives, clients in same-sex relationships may feel unable to participate and therefore may not participate, which could lead to premature termination, and we definitely don't want that. If a staff member, another example of language, or appropriate language, I have to say, is if staff members are overheard making jokes about LGBTQ people, allow derogatory language in treatment groups or informal activities, or do not refer to transgender clients using the name and pronoun that corresponds with their gender identity, LGBTQ clients may feel disrespected or unsafe. And that would also be an example of heterosexism. So we want to make sure that when we're talking about language, that we are safe, that we are appropriate, that we are inclusive, and we are mindful of our vocabulary, and we want to make sure that we're honoring the identity of the individual that is before you. Another piece I'd like to add as far as appropriate language, some of our LGBTQ brothers and sisters may not speak English as their preferred or primary language, so we want to make sure that we are also providing written and oral communication in the preferred language of our LGBTQ brother and or sister. So the next standard is going to be Standard 4, the Welcoming and Inclusive Climate Standard. And this standard talks about the climate of the Substance Abuse Treatment and Prevention Agency being welcoming and inclusive of all clients. This in particular is saying the climate of the agency goes beyond inclusive language. Many LGBT individuals look for signs of acceptance when confronting new environments and people. These clues inform decisions about disclosure and thus the degree of engagement and participation. And because we talked about confidentiality and safety, and we have been throughout the standards that we have reviewed, we want to make sure that we continue to be mindful of the individual's confidentiality and privacy. So a way in which you can show that you are inclusive or your agency is inclusive is to maybe put up a poster, have a sticker, a small sticker in the window maybe if you're wearing a badge, maybe a rainbow type of representation, or some type of identification that's kind of discreet, but also sending a message that you and your agency are welcoming of LGBTQ individuals. Another example of that would be if there were more types of representation of things that maybe the LGBTQ individual maybe identifies with, maybe more research could be done around that to make sure you're providing that in your agency as an individual in your office. So the next standard, and the last one here, is Standard 5. And that one speaks about linkages, referrals, and resources. We want to make sure that the treatment and prevention agency creates linkages with local LGBTQ communities and use appropriate referral sources for the LGBTQ clients. So this is about putting our feet to the pavement and really trying to find LGBTQ-specific resources and LGBTQ-friendly resources. We want to make sure that we are sending our clients or referring our clients to the most safe environment possible to continue their process of treatment and recovery. Okay, so now we're going to change up a bit. We're going to talk about basic terms for the LGBTQ populations. These are a few here that we see on this screen, but of course there are many, 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 many more. But for the sake of time, we're going to go over a few, and if there are any others that you know of, please feel free to email me at Dr. Williams, that's drwilliams1055 @gmail.com. So what we're going to talk about now is the evolution of language. And as we see on the screen, the language used to refer to sexuality and gender is constantly changing, and preferred terms vary by age group, ethnicity, geographic region, and other factors. Clients appreciate healthcare professionals' efforts to be inclusive and culturally competent. This includes a willingness to adopt and use appropriate terminology when delivering services to their community. If clients use a term you don't know, please ask them what they mean when they use it. And please let's not begin to use that particular term for everyone who may appear similar to the individual who provided it for you. We want to make sure that we are, again, stepping out in confidence and we're asking those questions that are culturally appropriate, inclusive, and thorough. So we want to make sure that we're doing that. So what we want to talk about now, or first, are terms to avoid. Terms to avoid are sexual preference, the homosexual or gay lifestyle, and down low or DL. Sexual preference implies that LGBTQ people could change their sexuality if they tried hard enough. And then the homosexual or gay lifestyle erases the vast diversity within the LGBTQ community and implies that LGBTQ people do not generally share and live by the same values and choices of most non-LGBTQ people. And then as far as for down low or DL, it is sometimes used by some gay, bisexual, or men who identify as men who have sex with men to indicate that they do not publicly disclose their sexuality. And the reason why this has been seen as a derogatory term is that in 2004, on an Oprah Winfrey show, it was the high rates of HIV infection among African-American women were blamed on individuals or African-American men who were engaging in sex with other men, and it was seen as being secretive and actually predatory. So we want to eliminate that secretive predatory aspect of the gay man, and that's why we will not use, and it's inappropriate to use the term down low, because that's what it's implying according to how it originated. The accusation falsely blamed a small, stigmatized subset of the population for problems actually related to drug abuse, poverty, and inadequate access to health care services. And providers should avoid perpetuating the stereotype by not using the term. So we do not want to use that term again. We want to use the terms that our individual clients identify with. And if we do not understand the term, we ask them their meaning behind it. Now, terms we should use or could use are lesbian, gay, bisexual, and transgender. And then there's also two-spirit. There's also genderqueer or queer. And then there's also same-gender loving. Now, two-spirit reflects many of our Native American brothers and sisters. Genderqueer or queer speaks to many of our youth. And same-gender loving is a reflection or an identity for some of our African American brothers and sisters as well. Other terms that will replace homosexual, again, are GLBT and LGBT, and then there's LGBTQ, and then there's also SMY that many of our youth use, and that stands for sexual minority youth. And then, again, as I spoke of earlier, there's LGBTQIA, and of course there's another A. And if we look, it says that the Q's are queer questioning, I is intersex, and A is ally. And of course the other A that we have is for asexual. Allies are used in a lot of our youth groups, our sexual minority youth school groups. Questioning is also used. For many LGBTQ individuals, queer is seen as a derogatory and disrespectful term. So it's very, very important, again, that we ask how our client identifies. So if we go on to more terms, we'll talk about sexuality and gender. As we see here, they're two separate things, and I believe, or two separate terms. I think historically some of us may have, including myself, have used them interchangeably, but we see that they're actually two separate terms. Sex has two meanings, male or female body, or a set of behaviors that culture designates as related to reproduction and or intimacy. And then we have gender. And gender is where we fit on the male, female, and masculine, feminine continua. So we can vacillate from where we fit or how we feel on any given day, actually. And the concept around that is that sexuality and gender are independent, and we all both have a sexual and a gender identity. The next one is about sexual orientation. And sexual orientation refers to the core sexual attractions and influences who people have sex with, who they love, and with whom they create a family. This may have a biological basis. Of course, research is still ongoing, and this is on a continuum as well. You can go from exclusively attracted to people of the other sex or gender to exclusively attracted to people of the same sex or gender, with many points in between. Now, the next question is, can sexual orientation be changed? And while there is no scientific evidence that these efforts are effective, there is evidence that they are harmful. They are harmful psychologically, socially, and spiritually. Now, the efforts to change someone's sexual orientation in youth or adulthood are opposed by those many organizations and associations that we see on the screen. So I want to say this one more time, that although there is no evidence that these efforts are effective, to change someone's sexual orientation is effective, there is definitely evidence that it is harmful psychologically, socially, and spiritually. Okay? So now we'll move into sexual identity. And a sexual identity or identities are labels people use to describe themselves and others. And the most common are straight or heterosexual, gay, lesbian, bisexual, asexual. And we have to keep in mind sexual identities may not match sexual orientation or behavior. And I wish we had longer than an hour for this webinar because we could definitely have a great discussion around these terms that I'm presenting to you right now. Very complex, very unique, and in my opinion, diverse and beautiful, and it would be a fantastic conversation. Now, one thing we have to be mindful of with sexual identity is that some people avoid labels, while other people describe their sexuality as queer or fluid. Again, we have to make sure that we're asking our clients how they identify and not imposing our own knowledge or assumptions on them based on what we've learned. The next term we'll switch to now is gender expression. Gender expression does not predict sexual identity. In other words, masculine women can be straight, or masculine, or how society sees a woman. If the society views the woman as masculine, she can absolutely identify as straight. If society sees the woman as feminine, or the societal norm for feminine, she can identify as lesbian or bisexual. Society's version of a masculine man can identify as gay or bisexual, or society's take on a feminine man, or what they would consider a feminine man, can actually be straight. Gender nonconforming people, regardless of their sexual or gender identity, are at risk to experience more harassment and bullying, anti-gay discrimination, and hate crime violence, including murder. And this is really due to a lack of knowledge, in my opinion, and fear of what an individual may not quite understand. And that's why it's so important to continue to have these particular trainings on the LGBTQ community so we can provide effective and equitable services and provide a sense of sort of knowledge for those who may not quite understand. So our next one we're going to move to is gender identity. Gender identity describes people's innermost experience and understanding of their gender. Gender binary refers to the cultural belief that there are only two genders, man and woman, and that gender must conform to biological sex, male and female. And then we have transgender or trans, and these are umbrella terms for people who have a significant cross-gender identification from the sex assigned at birth. Also with gender identity, we have under the umbrella of transgender or trans, we have transsexual, and which is a medical term for people who live full-time in a cross-gender identity regardless of their surgical status. We have a trans woman, MTF, or male to female, or trans female, which refers to a person assigned male at birth who currently identifies as female. And then we also have trans man, FTM, which is female to male, or trans male, which refers to a person assigned female at birth who currently identifies as male. And then we have genderqueer, which describes people who reject the gender binary and identify other than solely male or female. Then also under the transgender or trans umbrella, we have cross-dresser, or drag queen and drag king. Now, cross-dresser is described as a person, such as a straight male, who dresses in the clothing and adopts the characteristics of the other sex part-time. The medical equivalent is transvestite, implying illness. So to identify someone as a transvestite is doing a disservice and is no longer appropriate in our terminology. If a client identifies him or herself as a transvestite, obviously that's their right to do so, but it's not for us to impose that terminology on them. As far as drag queen and drag king, a drag queen is a man who occasionally cross-dresses, and a woman who occasionally cross-dresses is a drag king. The context is usually for entertainment, historical and cultural, or political reasons. Now, please remember, transgender people can be straight, lesbian, gay, bisexual, or another sexual identity. Now, how do we connect with transgender people as an agency? If we look at the screen, it says to connect with transgender clients, ask 2 questions. We ask about their current gender and their birth gender. So we want to make sure that we're asking them these questions to further contextualize the client's story and to give us a better feel of which direction we should be working in collaboratively with our client. Next we see is intersex. Intersex is a wide variety of biological differences of genitals, hormones, and or internal reproductive organs. Another way in which we describe intersex is sexual ambiguity. And we see here it presents in 1% of live births. Between 0.1 and 0.2% involve specialist medical attention. Some intersex conditions do not become apparent until puberty or later. Some identify as intersex. Some individuals do not. Some individuals identify as lesbian, gay, bisexual, or transgender. Others are heterosexual. So this is a more appropriate term to use than hermaphrodite. Hermaphrodite is another term that is inappropriate and no longer used in our terminology. So the next slide that we want to go to is actually gender dysphoria. And I'll speak about gender dysphoria really quickly. Gender dysphoria is a psychiatric diagnosis that uses that labels transgender and gender nonconforming people. And current treatments of gender dysphoria focuses on helping individuals to bring their bodies and gender expression in harmony with their gender identity, not vice versa. So I'll read that again. Current treatments for gender dysphoria focus on helping individuals to bring their bodies and gender expression into harmony with their gender identity, not vice versa. And efforts to change gender identity are no more effective than efforts to change sexual orientation. Instead of helping, they can cause lasting harm. So according to the DSM-5, there have been differences made between gender dysphoria in children and gender dysphoria in adolescents and adults. And what has been found is that in young adolescents with gender dysphoria, the clinical features may resemble those of children or adults with the condition, depending on developmental level. As secondary sex characteristics of young adolescents are not yet fully developed, these individuals may not state dislike of them, but they are concerned about imminent physical changes. And in adults with gender dysphoria, the discrepancy between experienced gender and physical sex characteristics is often, but not always, accompanied by a desire to be rid of the primary and or secondary sex characteristics and or a strong desire to acquire some primary and or secondary sex characteristics of the other gender. To varying degrees, with gender dysphoria may adopt the behavior, clothing, and mannerisms of the experienced gender. They feel uncomfortable being regarded by others or functioning in society as members of their assigned gender. Some adults may have a strong desire to be of a different gender and treated as such, and they may have an inner certainty to feel and respond as the experienced gender without seeking medical treatment to alter body characteristics. So that's new, fresh off the press from the new DSM-5 regarding gender dysphoria. What we come to on this slide is the terminology or the term coming out. And it is a lifelong process of discovering, exploring, and labeling one's minority sexual or gender identity and disclosing it to others. So that's coming out. Now coming out to others, we must understand is that it's a never-ending process that involves awareness of cues about what environments and people are safe or hostile, and whether the risk of disclosure will outweigh the benefits. So the coming out process is, it never ends for individuals, or I should say most individuals within the LGBTQIAA communities. So we have some resources and some referrals. We want to make sure that, again, the information that we are providing for our clients is LGBTQ sensitive, LGBTQ appropriate, and LGBTQ specific. We want to make sure that we find out if the clients are questioning their sexual or gender identity or in early stages of coming out, and if it is true, they may benefit from basic information and counseling on sexual orientation, sexual identity, and gender identity provided in a subculturally responsive manner. We want to make sure that we also provide access to substance-free activities and role models and other recreational, social, religious activities in the LGBTQ community. And we want to support the building or rebuilding of supportive relationships with friends, partners, families, and communities. Now, what we're going to move on to are treatment needs. Oh, before we go into treatment needs, I wanted to say something really quick about the patterns of coming out. Some people report knowing that they're LGBT at a very young age, even as very young children. The average age is 8 years old, and others come out later. And a common pattern is to report feeling different or having same-sex attractions in late childhood or adolescence, exploring sexual gender identities in later adolescence, and adopting a minor sexual/gender identification in young adulthood. So those are some of the coming out patterns. Again, because our LGBTQ brothers and sisters are individuals, these patterns may be similar and they may also be different. So we want to make sure that we're asking them about their experience around coming out, or if they have come out, to make sure, again, that we are contextualizing the client's story, that we want to provide the most equitable services and provide them with the proper resources and referrals if needed. So thank you for letting me backtrack really quick. Now we're going to talk about the LGBTQ treatment needs. Now, we talked about this for a short time, but we'll come back to it now. LGBTQ clients share the same basic prevention, treatment, and recovery services needs as non-LGBTQ clients, with the possibility of additional special needs in the following areas: mental and physical health, sexual health, spiritual health, economic empowerment, and political status and social support. So those, of course, some of the same needs as far as treatment and recovery services are needed for LGBTQ brothers and sisters as well as our non-LGBTQ brothers and sisters. But as we can see, there are some special needs that may be needed. I encourage all of us, with all of our clients, to touch bases with our clients on these following areas as well. Now, as far as mental health needs, LGBTQ clients need assessments for the following: stigma-related mental health care, physical health, transitioning, sexual health, and spiritual health. Now, if we look at this slide here, it talks about LGBTQ clients' needs assessment for the following. When we're talking about stigma-related health care, we're talking about recovery from past and current minority stress and trauma, coming out strategies for internalized and external stigma, and we're also talking about coming out resources and referrals. So those are all a part of the mental health needs for our LGBTQ brothers and sisters. So what we're going to talk about now is stigma-related care. And it states that stigma-related care, the higher prevalence of stress-related mental health disorders among LGBTQ individuals, creates a higher need to integrate mental health services into substance abuse treatment and recovery planning. So we want to assess for a higher likelihood of exposure to trauma. Now keep in mind, some of our LGBTQ brothers and sisters may not have had any type of exposure to trauma. That could be an issue as far as substance use and recovery. We want to make sure that we assess for symptoms of PTSD, a risk factor for substance abuse, and provide referrals for responsive therapy and medication. So we want to make sure that we are providing, we are all-encompassing when we're treating our clients. And we also want to make sure that we understand experiencing or fearing hate crimes increases daily levels of stress and for some results in PTSD. We also want to acknowledge the possible past environmental stressors and trauma, including harassment, bullying, political persecution, and violence. We want to make sure that we're asking these questions to get a better understanding of the efforts to change sexual orientation or gender identity, alienation and pressure to conform from family, friends, and communities, housing, education, and employment discrimination, including forced discharge from the military, abusive treatment by law enforcement personnel, secondary trauma from reports of anti-gay hate crimes. We also want to provide tools to recover from past emotional and psychological trauma related to living in stigmatizing and or abusive family, school, and community environments. So we want to use empowerment and imaging exercises to counteract negative self-image, and we want to use or refer clients to trauma therapy such as somatic experiencing grounding exercises, EMDR, and or CBT, cognitive behavioral therapy. So the next one, we also want to provide tools and strategies to cope with current internalized and externalized stressors. We want to talk about understanding the LGBTQ clients. For some have a conservative cultural background and beliefs may need help with the cognitive dissonance that they may be experiencing. Also, LGBTQ families with children may need assistance with social exclusion and bullying, and LGBTQ immigrant families and LGBTQ individuals living in ethnically identified communities with limited support may benefit from a discussion of alternative families and community building. Another one we want to do is we want to assess for domestic violence. Most studies report similar rates of violence in same-sex couples as in other sex couples. The main differences are because same-sex relationships are stigmatized, fewer resources are available for victims of same-sex violence, and this is especially true for men and trans men. And also, the abuser may take advantage of anti-LGBTQ social stigma and use threats of revealing the partner's sexuality or gender to others to control the person's behavior. Okay, so if we really think about stigma-related care, it's really talking about the prevalence of stress, the exposure to trauma, past exposures, in trying to provide support around past exposures to trauma, and also talking about current issues that may be presenting themselves and how to help our LGBTQ brothers and sisters in that regard. So our next one we want to talk about is physical health. As you see, we're talking about assessing for tobacco use, smoking-related physical health disorders, a desire to quit, and this is just an idea of what we should be assessing for in regards to physical health. Obviously, there will be other things that we should be assessing for in regards to physical health as well. We want to make sure that we provide our lesbian and bisexual women and trans men access to culturally appropriate gynecological services, including reproductive health care for those who require it. We have to remember some of our lesbian, bisexual women and trans men may have delayed or avoided reproductive health care and Pap tests and may be at risk for cervical and uterine cancers. So even if we do feel kind of uncomfortable asking those particular questions, although they identify as, for example, if we have an individual who identifies as a trans man, we still want to make sure that we're asking about their physical health and their health care services to make sure that, first of all, that we're thorough, we are exercising cultural competence, and to make sure that we are covering all our bases as far as how to best serve the individual. So the next one that we would talk about would be transitioning. And we will talk about we want to provide access to transition assistance for transgender individuals while in treatment. And that will be supportive, medically supervised hormone treatment. Educate staff about the proper place and use of injectable hormones if medically indicated for optimal results. And we want to provide education that hormone treatment and street drugs do not mix. So our next one will be sexual health. And sexual health will address acknowledgement and diversity without judgment. We want to make sure that we respect privacy and confidentiality of the client at all times. And we want to allow the client to choose their own labels or avoid them entirely. And we want to make sure that we're providing thorough education on preventing STIs, sexually transmitted infections, as well as assessing for sexual addiction. The next one we want to talk about is spiritual health. We want to make sure that we understand that the LGBTQ client's religious background can be every bit as salient an issue to address and honor as sexual orientation or gender identity. So we want to assess this on an individual basis and make referrals and interventions based on our actual knowledge of the client. And it's important for providers to keep an open mind just as they may be seeking the client to do the same. We're almost done. Another one for spiritual health, we want to make sure that we are assessing our clients for a history of spiritual trauma. For many, recovery involves a renaming of what spirit means to fit their own circumstances. Others may reject all notions of spirituality, particularly if religion was used as a weapon against their sexuality or gender. And reclaiming a sense of spirit is central for many to recover from severe trauma. We also want to make sure that we understand that some of our LGBTQ brothers and sisters come from conservative religious backgrounds, and it may benefit them if they're introduced to religious, spiritual, or meditative traditions and communities that are LGBTQ welcoming and inclusive. Many faith-based traditions have branches that are LGBTQ affirming, and some clients can also be directed to look outside their religion of origin for options and provided local resources to do so. And some may find atheism or agnosticism a positive alternative, or sometimes a step along the way, and that's in quotes, towards reclaiming a spiritual identity that works for them. And with that being said, it's been a pleasure speaking with all of you today. Thank you so very much for your time. And again, if you have any questions about my presentation today, you can see there is my email address on the bottom of the screen. If you would also like a longer training around LGBTQ treatment, I am also available for that, half day, 2 hours, full days, however you would like to have it. I can definitely adjust and modify the presentation according to your needs. So thank you all very much and have a wonderful day.